Good morning, and thank you very much for being here today. And thanks to WorkSafeBC for inviting me to share some thoughts with you, which I will do and need to finish. I'm just saying this because this helps me and structure my thinking. I need to finish at 9:40, so you can help me. If I seem to be starting to go, you could maybe just move faster. But I'm here to provide an overview for the day related to caring for people with dementia and what each of us needs to know. And it's each of us, and it doesn't matter what your employee is or whether you're a family member. But this is about what each of us needs to know in order to care and support people who are living with dementia and to do it well. But more importantly, I'm actually here to say thank you. I look around this room and I see people who I have met over the last 20 years of doing this job, and I am profoundly grateful for the work that you do, and I'm profoundly grateful for what you've taught me over the last 20 years, and that I keep learning. Jane and I were talking, Jane Devji and I were talking about how this work, you keep learning. And if you ever think you know what you need to know, you're wrong. And you need to keep learning, and you'll keep learning until the day you retire, and then you'll keep learning in other ways. But really, I am so profoundly grateful. So the work you do is actually sacred work. And sometimes it doesn't feel that way, but I'm actually also here to say thank you on behalf of the many people with dementia who you care for every day who aren't able to verbally say it. So please, just in this moment, accept the thanks, okay? And now let's talk about, fine, that's lovely. How do I support the people who I'm caring for who have dementia? What do we all have in common? We all have in common needs, all of us, okay? And whether you're the person with dementia, whether you're the staff person, whether you're a family member, whether you're the management, whether you're part of the health authority, or whether you're the Ministry of Health, they all have needs, and they all have different needs. And in actually talking about the care we deliver, you actually have to talk about all of these elements, but we're not going to be able to do that in 35 minutes. Today we're going to focus on staff needs. Okay. So what do I need to make a difference in caring for people? Well, first off, I need to understand the illness that we call dementia. Secondly, I need to be sure I see people with dementia as people first, and we'll talk a bit more about that. I need to see the behavior that I'm working with, or responsive behaviors, as the person with dementia's best effort to tell me that they need something. That's what they're doing. I need a way to organize my caregiving that's obviously going to help me anticipate the needs, and also to prevent the responsive behaviors as much as I possibly can. And I need to understand, this is a big one, that I am a powerful therapeutic tool. So if you didn't realize that you actually are doing far more than the tasks of your job, but that you are a therapeutic tool and the most powerful one that there is, then you need to open your eyes, and you need to think about this carefully. And the last thing is that I need to work in a setting that enables me to practice the kind of care that will help me to be as safe as possible. And we'll talk about what that actually looks like. So I'm just going to set the context in terms of reminding us, when we talk about the illness of dementia, what are we actually talking about? Well, we're actually talking about, as Jean said, the umbrella term for a group of symptoms that tend to come together, and they include impaired memory, and that can be trouble laying down memory or trouble retrieving the memory. Then you have to have one or more of aphasia. And when we talk about aphasia, we're talking about trouble with language, okay? Trouble with, and what kinds of trouble do we see when we're talking about people with dementia? What kinds of things do they have trouble with in terms of language? Word finding. So they have trouble finding the words that they need to convey. Yes. What else do they have trouble with in terms of language? They have trouble understanding. As the illness goes on, their understanding of the words changes dramatically. And they have a hard time necessarily, you may think you're speaking clearly, but the person with dementia is hearing something completely different. So they have trouble with word finding, and they have trouble with comprehension. They then will develop trouble called agnosia, which is trouble naming things or identifying things. And that might be objects, or eventually it might be people. And it certainly eventually is the surroundings in which they find themselves. So agnosia, trouble with recognizing objects and self. Then they may have apraxia. And apraxia is this odd thing that happens, which is that although my fingers and my muscles work perfectly, if you ask me to do something, I may look at you in a very perplexed way, and I may not know how to get those buttons done up on my shirt. But if you leave me alone for 5 minutes, all of a sudden I'll come out of the room with my buttons done up. And you'll say, how is that possible? Sometimes it makes you feel like people are manipulating you a bit. He knows how to do that. He's just pretending, or he just wants more attention, or he wants me to do it for him. But it's actually apraxia, where you're able to do something, but you're not able to make the connection between the conscious, let me do that, and the actual action. So that's why sometimes it's very helpful when we're working with people to get them going in an action and then let them move. But apraxia can sometimes create the impression that people are being manipulative. And then executive dysfunction, which is mostly what my family tells me I have most of the time, because I'm trying to do too many things. But executive dysfunction is incredibly important. It's the inability to organize. It's the inability to carry out a plan, even though you might be able to verbalize what you're going to do. It's the trouble getting actions going, so people may appear quite apathetic. They just seem to sit, and they don't initiate conversation, or they don't initiate activity without the invitation. There's disinhibition that is part of executive dysfunction, and what that means is people are impulsive in their behaviors. They don't think about things before they speak. So although you might think, your spouse might have executive dysfunction, because you wish they would think a little bit more carefully about what they say before they start speaking, in fact, people with dementia have that happen a great deal. And it may be also their behavior. They don't have the control to stop and think before acting. Just as you saw the man in the video, he suddenly became upset by the person who seemed to be trying to help him. And it was that suddenly something happened, and instead of thinking, this is an unusual situation, I don't recognize that person, I think I'll just tell her I'm feeling uncomfortable. Mary, I'm feeling uncomfortable. I don't have time to do that. All I know is I'm terrified, and boom, the action happens. So part of that is disinhibition. And as I mentioned, trouble performing tasks that have multiple steps to them. That's executive dysfunction. So just to say that, although as Jean mentioned, Alzheimer's disease is the most common form of dementia, and it's kind of the classic, or it's the dementia that we all think about when we think about the term dementia. We think about Alzheimer's disease, which is a gradual progressive illness, tends to occur in a relatively predictable manner in terms of the changes that you see, and doesn't happen with major steps in it. Vascular dementia is the dementia that occurs as the result of multiple strokes. So it's, and usually the two are mixed, we're finding more and more. But what we've learned from vascular dementias is that by controlling the risk factors for vascular dementia, we can we can work to prevent having dementia at all. And that's, even though we're controlling risk factors for stroke, we're actually controlling risk factors for Alzheimer's disease as well. So that's why this refocusing on diet, lifestyle, exercise is so important, as well as stimulation of the brain. The third type of dementia that we see quite commonly, and is probably the one that causes more challenge in terms of behavioral associated symptoms, is Lewy body dementia, which is an Alzheimer-like illness that has Parkinson's features as well to it. And people who have Lewy body dementia often have a more preserved memory, and they often will have some insight that something bizarre is going on for them, but they can't put their finger on it. Their behavior will often worsen as the day goes on. They may have multiple falls, and they often have profound visual hallucinations that are terrifying. So that's a different group from Alzheimer's disease. But going back to the video that you saw this morning, you have to know who is this person and what's the kind of dementia that they have, because that's going to very much influence how I approach them with their care. And finally, the frontotemporal dementias, which is another group, which is primarily challenged within the frontal lobes of the brain. And in that, you're going to see behavioral changes much, much earlier than you see memory changes. So you might see families will tell you that impulsively they've been caught shoplifting, or they've started to hoard, and they weren't doing that previously. They will tell you exactly how bad your breath is at the moment that you interact with them. They're very, they just say whatever's in their head. So that's a different group of people. And again, if you don't know that you're about to go in and give care to someone with a frontotemporal dementia, you're going to be surprised. So it's really important that we make sure that if I'm going in to help someone with their daily care, I know not only who this person is, but what their illness is. Okay, so we've purposely called these, the behaviors that we're talking about this morning as responsive behaviors. And that's a term you're going to be hearing more and more. Rather than challenging behaviors or excessive behaviors, it's responsive behaviors, because these behaviors all occur in response to something. And so the common ones that you'll see are either what we call self-protective, or they often look aggressive, but in most instances it's the person trying to protect themselves, and as a result is trying to get you to leave them alone. So self-protective or aggressive responses, self-protective or aggressive responses to other elders, calling out, repetitive questions, disrobing, sexual behavior occurring out of context. So there's totally appropriate times for sexual behavior at whatever your age. It's just when it occurs in the contexts that are socially inappropriate. Trying to leave and hoarding. So those are some of the responsive behaviors that we're talking about. So who develops behavioral symptoms? Well, it depends on the type of dementia, as I just suggested. And I don't have time to go into it all here, but studies show that over 90% of people who have dementia will develop behavioral symptoms at some point in their illness. Now, that doesn't mean they will all develop aggression or self-protective behaviors. Some people don't have that happen, and it's probably, the studies are so varied it's almost impossible to give you a figure, but 20% in the community, perhaps more, 20 to 50% in residential care. The behavioral challenges tend to occur the most in the middle to later stages of the illness, but in Lewy body dementia and in frontotemporal dementia, they will often occur earlier, and with any dementia they can occur at any time, but the tendency is to see them more with Lewy body and frontotemporal dementia earlier. And then it's important to say that behavioral symptoms wax and wane. So because you have a problem this month, doesn't mean that in 3 months you're going to have the same problem and that you require the same treatment. So it's very important that we're always asking ourselves, can we stop what we're doing, or do we need to change our approach now? Has this settled down and now we can use some other approach to deal and care for this person? Okay. So I'm a minute behind. I'm doing well. I just want to let you know. That's quite an achievement for me. So my question to you is, and my question to our society is, do you see, when you are working with somebody who has dementia, do you see a person with dementia, or do you see a person with dementia? The two are profoundly different experiences. And our society, as soon as you have that label of dementia, that's the first thing people start to think about. And that's when Jean was mentioning how people socially withdraw from loved ones or friends who have dementia, it's because they really are focusing on the dementia and forgetting that their wonderful friend is there, and I may have to work harder to stay connected to who they are and help them stay connected to who they are, but that's my job right now. That's what friends do for one another. That's what people interacting with one another do. We're all people first. And I think it's really important that, one of the things around person-centered care is it breaks down this us-them, right? There's no us-them, man. It's just we. We're all in this together. And if we constantly, say it's them or that old demented lady, we're going to be, again, creating problems for them and for us. So what is this person-centered care stuff? And why is it important in what we're talking about today? Well, person-centered care is a philosophy of care that was put together by Tom Kitwood, who is an English philosopher and psychologist, actually, in England, and it's been carried on and really now operationalized much more than he ever did. But person-centered care really has 4 key aspects of it. It really affirms the value of a person, regardless of their degree of impairment. So even if someone's in the very later stages of their illness, they are a person first, and they are a valuable part of our world. And they are how we manage to help them to stay alive emotionally is a key aspect of our work. Person-centered care treats everyone as individuals. So although there are aspects of care that may be the same for many, many people, I'm an individual first, and if my care is tailored to me, I will do far better, and I will do far better by you as a caregiver than if we do the same thing for everybody. This is that challenge of justice, you know, the notion of justice versus individuality. And the fact is, sometimes we say, well, you can't give everybody what they need. No, so in fact we give everybody the same thing, which half of them don't even want, right? And if we're giving them what they don't want, then they're going to show us that they don't want it. Perhaps if we tailored our care a little bit more individually, we wouldn't see so much resistiveness. So that's a big, big issue. So you have to treat everyone as an individual. It also adopts the perspective of the person with dementia. So that means I have to step into the person with dementia's shoes in order to really understand what they might be feeling in this circumstance. And the other most important part is that it provides a supportive environment. So a supportive social environment. So a place that really enables me with my dementia to function at the most optimal level that I can and feel as valued as possible. When I'm in an environment where I don't feel that, you're going to see far more of me showing you how unhappy I am. And as my verbal skills decrease, I'm going to show you physically. The other part of person-centered care, that I added is that you have to, as part of person-centered care, have optimal health care and optimal comfort care. So it's not all about the social realm of things, it's also about the biological and the psychological, and we'll come back to that. So the third thing I need to do is I need to understand what lies behind responsive behaviors. Well, responsive behaviors are the person's best attempt to tell me what they need in the context of a broken brain. Okay? That's what responsive behaviors are about. They occur in response to a need or a trigger, and therefore we call them responsive behaviors. Now, I think I'm going to just go ahead, and I may come back to the video. I'll come back to the video if I have time at the end, because I really think we need to get to the meat of this. So I want you to imagine that you're living with dementia, and we'll have that chance in the next piece as well. But dementia threatens, I want you to think about those things. I have trouble with language, I have trouble with memory, I have trouble knowing how to navigate where I am. I have trouble naming objects, I have trouble naming people, and I have trouble organizing my approach to life. So it threatens my ability to make sense of the world around me. Because if I don't have those skills, how is the world going to make sense? It really gets in the way of my ability to hold on to who I am as a person. And that's made worse by our society's view of people with dementia, that they're just really an illness. It also threatens my ability to verbally express my feelings or my desires or my needs. And then finally, it affects my ability to solve problems on my own. So I might be trying to solve problems on my own when I don't have those skills. So what's the word that comes into your head when you think about a world like that? Scary. It can make the world a scary place. And unfortunately, for caregivers and people who are providing care, you are meeting somebody at their most vulnerable. You're meeting somebody when they're at their most scared part of their life. So imagine how that's going to need to alter how we approach people. So how, though, do I understand what the triggers might be and the behaviors that I'm seeing? It's our job to actually decode the needs that the person with dementia is trying to express. Okay? Our job. So the question, though, that I put to you, is it your job alone? If I'm a manager or I'm a care aide or I'm a nurse or I'm a doctor, is it my job alone to figure that out? No. Absolutely not. I can't do it. Just as it takes a village to raise a child, it takes a team to care for an elder with dementia. Okay? It takes a functional team. We use that word team as if it means something. It takes a functional team. And who's that? Who's on the team? Well, the elder themselves may, or, we need to talk to them first about what they're experiencing and try and make sense, too, of some of the language that they're using that if you just kind of looked at it on the surface doesn't make any sense. But if you look at it in the context of who they are, oftentimes they're trying to tell you something very clearly. Family members are part of the team. Friends are part of the team. So they have all kinds of information and they have all kinds of abilities that if we don't tap into it as a partnership, we're going to miss and we're going to lose. Direct care staff, nursing staff, allied health professionals, physicians, managers and administrators, we're part of the team. So that's great. How do we actually decode the behaviors? Well, you can't do it willy-nilly, okay? I'm going to tell you. You can't say, well, it's all this or it's all that, or you can't make assumptions. You have to actually use some kind of organized, person-centered approach to decoding behavior. And it might be the GPEP model. You're going to hear a bit more about that. It might be the PIECES model that they use in Ontario. Or it might be the need-driven dementia-compromised behavior model. And I'm just going to touch on that. Now, the funny part is I was looking through a presentation that my friend Linda Bullock put together some time ago. And I didn't know Linda was going to be here today. But when I saw her, I said, oh my gosh, I'm using a slide from an old presentation, which is, aren't I glad I put Linda Bullock, formerly with PHC Violence Program, right? That was good. And Linda, this is a really important concept when you're trying to understand responsive behaviors. Just look at the top row. You have fuel, right? And the fuel may be scattered over the room where that person, is, because their energy is kind of scattered around them. You add a trigger or a match to that fuel, and you end up with a fire. Okay? So what I just want to touch on is the fuel or the risk factors. That's what's going on in the background of this individual. The trigger could be something that happens in the here and now. I'm cold. I don't like your tone of voice. I don't understand what you're trying to say to me. So that's the here and now. And then the fire will be, in this case, we're talking about the aggressive response. So how do I sort out what's the risk factors? Why is that important? Well, we said that the kind of dementia the person has may help us to predict the kinds of responses that they're going to have or what we might see in terms of their behavior. So I need to know what's this person's cognitive strengths, what are their challenges. I need to know what their psychiatric needs are. Do they have a clinical depression? Because we know that people with depression and dementia have a far higher incidence of aggressive responses to things, as do people who are delirious and demented. So we'll talk about, you need to tease that out. That's my job. Medical needs, pain, constipation, infection, all those things. If we don't know what's going on in the background and we're just trying to be nice to people, that ain't going to go too far. So we need the whole package, right? So medical needs, medication needs, psychosocial needs, and that goes back to who is this person and what is their story. And just not on a piece of paper in a file, but what does it mean to me when I'm helping this person going through their day? What are the spiritual needs of this individual? What provides them with meaning? And how are we incorporating that into my interaction even? And what are the cultural needs that this person has, or my own cultural needs, and how that's going to influence my approach to care. Then the here and now triggers of the emotional needs, the physiological needs, as I mentioned. What's going on in the physical environment? Have you ever tried to have a serious conversation with someone who has dementia in the context of a hallway where there's 400 people going by and there's people pushing carts and you actually think you're going to be able to have a conversation that's actually not going to overwhelm a person? Sorry, not going to happen. So if you really want to have a conversation with someone about something that's important, we've got to be in a quiet place. And we have to be in a place where I know you're able to attend to what I'm talking about. So what's the physical environment? And have we set the physical environment up for failure or success? People urinating in garbage cans. Well, what do you think most of that is about? Is that we have maybe not set up the physical environment for them to be able to get to a bathroom or recognize a bathroom easily enough. So those simple things, but they create all kinds of challenges for us. And then the social environment, and this is where we're going to talk about me as the therapeutic tool. Then I do want to touch on the fact that there are systems needs, the bigger needs that make our life more of a challenge as caregivers. When you talked about the beautiful healthcare system, you know, I think that we've all grown up in a certain model of care, and it has focused on task. And that was what we learned. We learned that we were doing care, right? We were doing Mrs. So-and-so. Have you done Mr. So-and-so? I've done Mrs. So-and-so. Well, you don't do people. You are with people and you help them out, right? So we need to be helping with rather than doing to. The notion that we as healthcare professionals are the experts and you as the family member, well, thank you, but we'll take it from here now. Not going to work, because I'm fairly confident I know very little about your mother. I need you, and we need to figure out how we're going to approach this together. Care that's designed for the institution rather than the individual. And that's, you know, that's the nightmare of breakfast will be served at 8 o'clock, and all those 42 people had better be in that dining room. Happy or not, they're going to have their breakfast then. That's our old way of thinking, and we've created systems where we're setting ourselves up for danger. Staff education, you know, and how it's provided. This is lovely, glad you're all here, but the big place where this needs to happen is when you're providing the care. Okay, so I'm glad you're here, glad you're thinking about these things. Now, how do we follow this up with actual education that's going to make a difference in my real place of work? Staff empowerment, and that's been shown that places that really get staff involved in decision making and involved in how we can do things together have better outcomes in terms of quality of life for the elders who live there, as well as the staff themselves, as well as decreasing violent outbursts. So staff empowerment, and that's empowerment is a fascinating word now. That doesn't mean that it's about staff getting everything they want. Okay, we might wish that were the case, but it's not about that. But it's about saying, we have this issue, how are we as a community going to deal with it? How are we going to set up things that will work for both staff and elders? And staffing levels, funny that that's at the bottom, isn't it? Should be at the top. Full recognition that person-centered care without adequate staff is very hard to do. On the other hand, I have to tell you that if you provide me with triple the staff and I keep doing the same old stuff that we've always done, you will not change the face of care. If you have more staff and don't rethink the way we deliver care, we will not get anywhere. But we do need more staff. Gordo, are you listening? We need more staff. Okay, thank you. That was my political comment for the day. And with your opinion polls being so low and all these people here have a vote, I would suggest you listen. Thank you. Okay. All right. So part of the other piece is we take that information and we create an individualized care plan. Lovely again. If it just stays on a chart and no one looks at it, it makes no difference. So we have to actually, how are we then going to get this plan into place? And that's part of the leadership and part of the modeling and part of how we function as a team. But it does work when we get it going. I need to recognize myself as a powerful therapeutic tool. The majority of aggressive or self-protective behaviors that we see are in response to care. And I really need, before I go in to provide care for someone who's at major risk for being frightened and overwhelmed, is I really need to check my attitude, and I need to check I need to be mindful. Before I enter this room, I need to actually take, if I'm tense, and I know this person is going to respond probably in an overwhelmed way, I'm best to back up against the door, take 3, and I mean it, cleansing breaths. Okay, slow yourself right down. Because it's, 10 seconds that might take you? But if I walk in and I'm like this, what is the person with dementia going to feel? Ah, we're off for the ride. So I have to center myself before I go into that room. And if you've never done any mindfulness exercise, or this word seems a bit weird, it's what we all actually need to be doing in our society to get ourselves centered and comfortable. I need to connect with the person socially before I deliver care. So it's not, actually I'm not sure whether that was an example of care I would like to see or I wouldn't like to see when she walked right in and said, I'm going to put the head of your bed up, but she actually did it as she, instead of saying hello, having a conversation first, maybe 10 seconds of, I'm so-and-so, and you may need to remind the person every day, I'm going to be with you for the day, we're going to have a great day. Setting the tone, it's everything. Before you start putting the head of the bed up, right? Not for me. I need to know who's going to be there for me first. I need to use the caregiving situation as an opportunity to have a meaningful conversation. So if there are two people in a room helping someone with care, do you think it's a good idea to talk about your next break or holiday? No. I'm here helping Joan. So let's very quickly think about the things Joan likes to talk about. Let's connect with Joan while we're delivering the care. That may be the most meaningful interaction Joan has throughout the day. And you have the power to do that. So I have the power, you do as well. I need to back away when the tension starts to rise. And we saw that this morning in the video. So I can feel when things are going down a path. Before I get the fist, I can feel the fist coming. And I need to say it's okay. I'm just going to, hey, you're feeling pretty stressed. I'm going to just go and have a little break. I'll be back in a couple of minutes. You just, relax. But before, because otherwise, if you push through, you'll get the fist. Often my approach can be, I can either be a day maker or a day breaker, depending on my feeling in the room. I can provoke aggression within 5 seconds if I want to, or I can make this the person's best start to the day. And sometimes I have, and sometimes I have no control over that. I'm not pretending that I always do, but often I can. And so it's important to say, my job is not a care aide. My job is I am a day maker. That's my job. And that's my job as a geriatric psychiatrist too. I need to check in with myself. How am I today? And if I'm having a hard time, then maybe I need to spend a little time talking to my teammates and really know that they're going to be able to, help me perhaps in my day when I might need more help, and then I'll help them when they're having a rough day. And then finally, I'm going to ask you this question, because this is a question you need to ask yourselves. Is this work the right job for me? Because if you're in the wrong line of work, your chances of being injured in the job are far higher. So you want to be sure that I'm in this job because I really want to be here and I really want to make a difference. Thanks. Oh no, hey. I was saying thanks to Sheila for showing me it's 5 minutes. No, sorry, you're stuck with me for another 5, sorry. So, I also want to share with you that because I mentioned you have needs, right? We all have needs. And in response to your unmet needs, you will start to develop responsive behaviors. So if your needs are not being met as workers, you too will demonstrate responsive behaviors. And you too will actually suffer. So not only, I didn't even put injury up there, but increased sick time, discord with my teammates. I'll start treating the person as a task. I'll become irritable with the person who's receiving care. I will avoid the person who needs care because I just can't stand it. I'll provide care too fast just to get out of there as quickly as I can. And then no one wins and injuries increase. So when I talk about I am a therapeutic tool, if I don't understand that and I don't use those skills wisely, this is what's going to happen. Okay. So finally, I need to work in a healthy, caring environment that empowers me to provide good care. So I need an organization that's actually interested in me as a person. Okay? I need my leaders to care about who I am and what's important to me, and to know me. I need an environment that's committed to providing this kind of person-centered, individualized care, and actually, what is that, and is taking the steps to move in that direction. I need a workplace that values my contribution and encourages my feedback and involvement in the way this community works. And I need to work in a place that keeps teaching me and upgrading my skills, and where there are adequate numbers of staff working collaboratively to provide care. Now, I need to tell you, the other part of that is you know, different places have different staffing levels, and some places with lower staffing levels have great outcomes for care. How do they do that? It's because they've got this aspect of person-centered care and person-centered leadership. So I don't think it's not all about the people, but I do acknowledge there is a large contribution of that. Okay. And finally, so dementia response behaviors occur because of unmet needs, and those will be biological, psychological, social, and environmental, and systemic. A person-centered care approach is required to decode the response behaviors and understand what those needs are that are being expressed. I am the only part of this environment over which I have any real control. True enough. You know, I can't control you. I can't control you as a boss. Only person I really have any control over is me, and so I need to see myself as a very powerful therapeutic tool. A person-centered care model benefits all the members of the community because we're looking at everybody's needs and trying to balance them effectively. So therefore, we used to say person-centered care is a nice thing to have. Person-centered care is actually about creating a culture of safety. And it's no more nice to have, it's an absolute must-have. And we'd better take that journey as soon as possible in order to create environments where our workers are safe, our families feel confident, and our people with dementia feel secure. So thank you very much.